Hello, welcome to the sixth and final installment of our COVID-19 webinar series made possible through a partnership with the Department of Labor and Industries. We are so appreciative of this opportunity, and all of our webinars are available on our EHS-International YouTube page. This is my favorite talk in the series. Because it's going to talk about business resilience and planning for the next pandemic and what you can do beyond COVID-19. My name is Shonnessy Gilmore. I am a certified industrial hygienist working at EHS-International. I have a background in microbiology and public health, and I'm excited to present this webinar. COVID-19 from the beginning posed a lot of unique challenges. We had dealt with pandemic influenza, various pandemics throughout the years. Every 5 to 10 years, you can more or less expect a pandemic. And a pandemic is a disease outbreak that spans multiple countries or continents. COVID-19 has made it to every continent in the world. It was really unique because it had asymptomatic spread, meaning people who didn't have any symptoms were still able to spread the virus. And some people got very sick from that and died. But that's pretty unusual. Usually you can tell who's sick based off of their symptoms. And we had really limited testing up until fairly late into the pandemic. So if someone was potentially exposed, a lot of times you had to rely on whether or not they got symptoms at the beginning of the pandemic because it was too hard to get tested. So people would just have to isolate for a couple of weeks. So that's a very unique challenge to COVID-19. The next thing that made it so unique was it is airborne and droplet-borne transmission. So airborne and droplet-borne transmission are very similar. Droplets are larger, they contain more saliva, they probably have more virus in them, and the virus is a little more protected because the saliva coats the outer membrane. And then airborne are very small particles. A droplet tends to fall to the ground about 6 feet max from the symptomatic or from the person who's sick. Airborne transmission can go as far as 20 feet away, so it has a lot wider spread. There are few diseases that are actually qualified to have the airborne transmission that get into those very, very small particles. So there was a lot of debate at the beginning on whether or not COVID-19 qualified for airborne transmission. Unfortunately, that sort of debate really delayed protecting people. It delayed getting the statement out that you should social distance, you should wear a mask, you should avoid indoor spaces. So that's a challenge that was very unique to COVID-19. Coming into this fall and winter, we might end up with more challenges from variants because they might be resistant to our vaccines or require development of new vaccines. They're already talking about how COVID-19 booster shots wouldn't so much be the same shot that you get this year as a completely different shot designed to give you have you build antibodies for new variants. And then COVID-19 is an emerging infectious disease. And what those are diseases that in the past 2 decades have shown increased frequency and spread among human populations. So in my previous webinars, we talked about how COVID-19's actual name of the virus is SARS-CoV-2. And what that is severe acute respiratory syndrome, which if you remember the original SARS outbreak, the original SARS virus is now called SARS-CoV-1, and it's the virus that causes COVID-19 is 79% similar to SARS, and it's about 50% similar to MERS, which is in the same family of coronaviruses. So things like influenza, coronaviruses, these all have the potential to become pandemics, and they're emerging infectious diseases. Variants, there's variants of concern and variants of interest. And what these are is viruses have tons and tons of usually insignificant changes to their RNA, the genetic material that make up the virus, as they move from host to host. And usually these little variants don't do anything significant. They don't change that much. But on occasion, you'll get a change to the spike protein on the outside of the virus membrane that allows it to attach to your cells and infect. And that change might make it more resistant to the vaccines, which are designed to help your body recognize those spike proteins. Or you might have a mutation that makes it transmissible at half the distance, or at twice the distance, I apologize. So it might be able to spread a little bit farther. The airborne particles might have more impactful virus particles that are able to infect, or you might need half the dose. If you needed 1,000 viral particles to be inhaled to get sick, you might only need 500. And these numbers are just estimates. They don't know exactly how many particles it takes to make you sick. They don't know the viral dose just yet. They estimate it's between 100 and 1,000 viral particles. So this is just giving some of the different variants of concern and interest. The B.1.617.2 variant is what they're calling the Delta variant. And right now, they're very concerned with the potential of this variant. So talking about variants, the more a virus spreads, the more it has potential to develop a variant, and the more it has potential to develop a harmful variation. So the best thing you can do is prevent the spread of the virus. Do not let it run unchecked through the population. That's why places that had bigger outbreaks, California has its own set of variants, India has its own variants, the United Kingdom has its own variants. They had more likelihood of developing these harmful variants. So I know masks aren't required for vaccinated individuals, but they should still be worn in crowded areas or anywhere where it's the rule of the room, so to speak, or a government rule like a medical facility. But I really think masks are one of the most simple ways to protect yourself, especially as we don't know what we're going into this fall and winter in terms of variants. Distancing, and then of course vaccinations. We absolutely have to get to at least 70%, and I'd like to see at least 80% of the population vaccinated to really end the spread of this disease. Most likely we're going to have endemic COVID-19, which means it'll be in the background, like in the winters, people will get more sick with COVID-19 because we're more indoors, we're in closer quarters, there's more potential for things to spread. But the best possible thing you can do is get your vaccination. Should they come out with booster shots next year, get your booster shot. It's the most effective way to keep these dangerous variants from emerging. As far as getting people in your company to get the vaccine, you should really encourage your workers to get vaccinated by giving them paid sick time to get their shot and recover from it. you should always lead by example, get your shot, and make sure your team knows that it is a priority, that it's something that's really important to you. And then stop misinformation. Our last webinar talked a lot about misinformation and getting direct sources and the best information. And then as far as vaccines, you can get more information at the Department of Health website listed here. Are there any questions at this point in the talk?
Yes, looks like we have a question. It says, what is the difference between COVID-19 antibodies that you develop from exposure to the virus and antibodies you develop as a reaction to the vaccine?
So antibodies you develop from the virus, they don't seem to be as long-lived. In studies, some people, they're still active a year later. Others, they're completely gone at 3 months. From a evolutionary standpoint, it's better if you're a virus to not produce long-lasting antibodies, because then you can reinfect the host again and again and again and keep spreading. The vaccines, they use a thing called messenger RNA, and this is the Pfizer and the Moderna vaccines. This is not the Johnson & Johnson vaccine. They use mRNA, which is messenger RNA, to deliver a dupe of those spikes that are on the outside of the virus membrane. And that dupe is delivered to your cell by the messenger RNA, and your body produces some of those just like basically free-floating spike proteins. And then your body has an immune response to that. It sends cells to recognize and form antibodies specifically to those spike proteins. And then once this has happened, the messenger RNA is broken down, and the free-floating, basically dupe spike proteins are broken down and passed out of your body, basically passed out of the cell as waste. So it doesn't do anything to permanently change your DNA or anything like that, but the vaccine works to recognize those outer spike proteins. And that's why we're so concerned about variants. So far, both Pfizer and Moderna have really good records with the variants, but there is a potential that a variant could mutate those spike proteins so much that your body doesn't quite recognize them based off of the vaccine. And so then they would need to develop a new vaccine for that. The nice thing is these vaccines, these mRNA vaccines, can be developed very quickly, and they're already starting to develop boosters for next year. So I think we'll be prepared, but the most important thing people can do right now is get vaccinated. Just some statistics for Washington State. The vaccination chart, I did get the data is supposed to be from June 20th. It doesn't quite match what the CDC or Department of Health have. I'm just going with it. I think it's better to assume less people have the vaccine than more, because I think the focus needs to really be getting everybody vaccinated, everyone who's eligible, which right now is anyone 12 and over. And the vaccination rates can really vary, even by town. I live in King County in Auburn, and we're about 50% vaccinated. Places like Sammamish, about 87% vaccinated. So there's a lot of variation, and I don't think you can just trust based off of where even your county is doing as a whole that enough people around you are going to be vaccinated. And then as far as cases go, there have been just shy of 450,000 cases in Washington State. And we've had 5,820 deaths in Washington State. This is tragic, but comparatively, we have had a fraction of the deaths seen in other states because we had such strong control measures, and we do have a lot of people that are able to work remotely, and we adopted masks really early on, and we just did a lot as a community to respond to this outbreak and have, I think, one of the best responses in the country. As a reminder for Washington State COVID-19 requirements from labor and industries, you must have a written safety program, and that's going to indicate who your COVID-19 supervisors are, what training you're doing for your people, what are your sanitation and hygiene practices, how are you going to have social distancing, what your mask requirements are. And as a reminder, unvaccinated employees are still required to be in a mask right now. What your vaccination policy is. Again, if you can, encourage your workers to get vaccinated and provide them with time off to do so. And then what you're going to do if any of your employees get sick with COVID-19. As you start bringing people back to in-person work, you might want to consider upgrading or increasing your ventilation system. You can add more outdoor air. It can be as simple as opening windows and doors or doing fresh air flushes, or you can add MERV 13 filters. Those are the filters everybody wants to get their hands on during wildfire season for smoke. So right now you can still buy them in stores. In about a month, you probably won't be able to. So it's a good idea to start making these changes ahead of time. I focus a lot in some of my other talks about the mental health issues and the dynamics of bringing people back to work or doing in-person work. And it's really important to address your employees' health and safety concerns. I know sometimes people can get so excited to bring people back to the office that they aren't fully aware of what their people actually want and what would help them produce the best and the safest environment. There are still unknown impacts as far as, the 6 million Americans who take immune compromising drugs like steroids. It's unknown whether the vaccine is as effective in them because they're on drugs that make them have less of an immune response. So those employees might not be ready to go back to the office. So just working to make sure your employees feel safe and that you're doing everything in the best, most scientifically proven way possible. There are tons and tons of resources for this on the Washington State Labor and Industries coronavirus page. And then our company, through this partnership, has videos, webinars, blog entries on our COVID-19 education page. And then just an update, on March 12th, they released a national emphasis program, NEP, for COVID-19, and it listed the primary facilities that were most likely to get inspections to make sure they had all of these protocols in place and they were protecting their workers. And that's, of course, going to be factories, medical facilities, people where they have the most exposure. Construction's a secondary enforcement group on that. And states needed to have equivalent or more stringent rules within 60 days. So we are past that window to protect their people. Do we have any questions before we go on?
Yes, we have one question. So it says, why does the vaccine cause symptoms such as fever, body aches, and other symptoms?
Mainly because that's your immune response. So it's a two-part vaccine, or at least the mRNA vaccines are a two-part vaccine. You get the initial one, and most people who haven't already had COVID-19 they mainly have, a sore arm, which is common with any injectable, but they tend not to have much symptoms, maybe a little bit of a headache or tiredness the next day as their body starts to have an immune development. And like I said, their cells are starting to make those little fake dupe protein spikes. And then the second shot is what gets people if they haven't already had COVID-19, because then you're getting another dose, you're producing more of these, but your body knows how to fight them. And the way your body fights invaders is by having a fever. It raises the temperature to kind of cook everything. So it's your body's natural defenses that are giving you these reactions. And then the theory is that if you already had COVID-19, and like I said, we don't know how long or how good the protection from having COVID-19 is, but they found that people who've had it tend to have more severe reactions to the first shot. And that's because your body probably already has some amount of antibodies designed to know those spike proteins and react to them. So you're getting your second dose response with your first one. That said, they still recommend that people who've had it get both doses of the shot. It's possible in the future, as we know more, that they might say, oh, only one shot for the people who've got confirmed cases. But again, don't know how long the antibodies last from the actual infection from the virus. So now the meat and potatoes of this presentation. Understanding how diseases spread is the most important way to protect yourself from them. It allows you to make a plan and adjust things for your company, your personal life, everything. And like I said, there's going to be a pandemic every 5 to 10 years. It's entirely possible we'll be dealing with a resurgence of COVID-19 this winter. That's a variant that maybe our shots aren't effective for. So understanding how diseases spread is so important for preventing that transmission. So airborne diseases, it's a very small number of diseases spread by aerosols, which are very, very small particles that can travel up to 20 feet, and they can linger in the air for up to 3 hours. Examples of diseases like this are COVID-19 and measles. And measles is far more infectious than COVID-19. So it only takes a very small amount of measles particles to infect someone. And that's a disease, again, that has a very effective vaccine. Droplets, like I said, they're bigger. They can travel about 6 feet and they can linger in the air for about half an hour. Examples of that are COVID-19 and influenza. Fomites are an object that can spread disease through contact, such as a light switch, a door handle, locks. So basically somebody who's sick got these, touched their face, blew their nose, coughed into their hand, and then they touched a doorknob, and then you go and touch that doorknob and you touch your face, and then you could get sick through that. And influenza is a good example of a disease that's spread through fomites. In the beginning, they thought that COVID-19 was spread through fomites in a similar way to influenza. And that ended up not being the case. COVID-19 is very, very rarely spread through fomites. And the situations where it would be are kind of strictly medical facility, like in a COVID ward, there's a lot higher risk of fomite transmission than in day-to-day. It doesn't survive that long on surfaces. Vectors are organisms that spread disease. So fomites are objects, vectors are organisms. So mosquitoes and biting flies. So diseases that are spread by them are malaria, West Nile. And then you have direct contact. So that's a disease, a pathogen that survives best in or on the human body. So for example, HIV really doesn't live that long outside of the human host. And then bloodborne, these are pathogens that live in human blood. And an example is HIV again. And if you notice, diseases can spread through more than one route. I mean, we have airborne and droplet for COVID-19. We have droplet and fomite for influenza, direct contact and bloodborne for HIV. So your response is really going to vary depending on the type of spread. You know, airborne and droplet-borne things, you can put people in masks and have them distance, and you significantly reduce the risk of transmission. Fomites, you can use, you know, good hygiene, sanitary methods. You can have things cleaned on a schedule, encourage hand washing. Vectors, you might use mosquito netting, certain pesticides, things like that. And then the direct contact ones, MRSA is a skin disease. It's methicillin-resistant Staph aureus. And that would be, you know, don't have people share PPE. For HIV, needle sticks are the main culprit of transmission. So having a really strong program for how you dispose of sharps and bloodborne pathogen training for your people, those are things that prevent the spread of HIV. So going into these modes of transmission even more, you have to think about how your work environment impacts the mode of transmission. So using COVID-19, again, airborne and droplet-borne. So you have your people distanced, masked, mostly outdoors, or working remotely if possible. HIV is a bloodborne pathogen. It needs to enter the body to infect. It really doesn't survive very long outside of the host. Again, greatest risk is needle sticks in healthcare settings and improperly discarded needles, you know, on a construction job site, things like that. So this chart goes over different modes of transmission. So general transmission, it has abiotic, which are things that are not part of, you know, your biology and organisms' biology. Factors, wind, water. So wind could have you inhale spores. Water, you could get an amoeba through the skin. Then you can have person-to-person contact after that and spread it. There's, you know, still a lot of speculation about how COVID-19 originated. The most likely scenario is exactly like SARS, where it had originated in, you know, a bat or something similar. And, you know, someone goes to their attic to do spring cleaning and gets exposed to the bat droppings and gets sick, maybe even with asymptomatic transmission, goes about their day-to-day life and spreads it unto others. And then again, under general transmission, we have these animal vectors. So we have mosquitoes and fleas. And then human to human contact, which is the main thing we can control in the workplace. So again, direct contact is the pathogen lives best inside the body. Indirect contact would be those fomites, door handles, and it's a pathogen that can survive well outside of the body. And then droplets, you might get a larger dose of virus or bacterial particles in these saliva containing droplets, but they typically still don't survive that long. With COVID-19, the maximum survival time is about 3 days. outside the body, but that doesn't even mean it could infect at that point, because there might not be enough surviving to cause infection. It's got a half-life of about 6 hours, which means that 6 hours from leaving the human body, half of the particles that you expelled are no longer viable. And then fecal oral transmission, these are your kind of foodborne and waterborne diseases. I'm not going to go into them much for this because those are not typically pandemic producing in this day and age. And they're also not typically things you deal with too much in an office setting. You know, you could get norovirus from a company picnic type of thing or a potluck, but everyone gets sick and it's kind of very short term. Before we start with building an infection control plan, do we have any questions about routes of transmission?
No questions so far.
All righty. So an infection control plan is a program you typically see in a medical facility, but they've started to build them for COVID-19 response. And really, they're going to be an important part of building resilience for a business going forward. So I really think that businesses should have an infection control plan. You can call it whatever you want, but the principles of what goes in it and how your company use it are fairly standardized. So a good program is going to follow the main principles of eliminate as much as you can of potential sources of exposure, administrative controls, which are changing how people work. You know, if you have to have in-person work, maybe you have a night shift and a day shift, and that way people aren't, you cut the occupancy of the space by 50%, or educate people, you know, if it's something where hand washing would really prevent the spread of the disease, educate people on hand washing, have programs in place to facilitate this, you know, a timer, training for your people. Engineering and environmental controls. So that's how you isolate people from the hazard. So you might build barriers. If you had an open concept office space, you might build barriers that make it so people's breathing zone doesn't allow particles to travel as far. You might increase the ventilation or filtration system. And then at the bottom, you would have hygiene, sanitation, and PPE. And I always say masks are one of the most important things. They are considered PPE, which is at the least effective. And the reason it's considered least effective isn't because masks don't work. It's because you have to rely on people to use them and use them correctly. So that's why those are always considered the least effective things, because you're relying on people to personally make the right choice and do things correctly. If this sounds familiar, it's because it's the hierarchy of controls. This is the standard pyramid used for all workplace safety and health. So you always want to go from most effective to least effective. So it goes elimination, substitution, engineering controls, administrative controls, and PPE. To build an infection control plan for your company, you're going to first focus on eliminating the hazard. So you're going to recognize the potential for different types of pathogens. So how are they spread? You know, how your company responds to pandemic influenza is going to be a little bit different than how they respond to pandemic COVID-19. The influenza, there is going to be more of a focus on cleaning surfaces. Are there asymptomatic carriers? You know, Will we be in another situation like COVID-19 where people can make other people very sick but not show any symptoms? Will you be able to test for the disease? And then administrative controls. Who's going to keep your infection control plan updated? You need to go through it at least once a year. And then anytime there is an event or a pandemic, you need to be ready to update and modify it to keep up with it. As I'm sure everybody learned in the last year, the pandemic's a very dynamic situation. There is new information every day, even multiple times a day sometimes. So who's going to maintain your plan? How are you going to train people? You know, are you going to do annual training? Are you going to send the plan out? How are you going to train people once you have an actual pandemic to respond to? And then what's your policy as far as preparedness? This image on here is called the chain of infection, and it's a really important, fairly complex concept. And you start at the top with infectious agents. So you need to understand what types of potential diseases your company could be dealing with. So there's bacteria, fungi, parasites. Prions are things like mad cow disease. It's not really going to be something that impacts most companies in America. And then the next thing would be, what's the reservoir? Where does this infectious agent spend time to live, grow, reproduce? Is it in people? Is it in the water? Is it in food? So where does it reproduce? And then how does it leave the reservoir? So that's called the portal of exit. And is it like HIV? It comes out in the blood. Is it, you know, more like influenza and through mucus secretions? Is it something like MRSA and lives on the skin? And then the modes of transmission, which I talked about at length. So you have physical contact, droplets, airborne. Like I said, understanding how things are transmitted is the most important way to understanding how you prevent them from spreading. So then the next thing on the chain is the portals of entry. How does this infectious agent get into the host? So could be mucous membranes, the eyes, nose. You could breathe it in and have it be your respiratory system. Digestive system, that's more the foodborne, waterborne. Broken skin would be things like, could be HIV with a needle stick, or could be things like a staph infection, things like that. And then the final thing to consider is susceptible hosts. People with immune deficiencies like diabetes, or who take medicines that can lower their immune system. A burn would make you more susceptible to things like MRSA or a staph infection. Surgery, that's why they're so careful to have people completely scrubbed down. It could also lower your immune system while you're recovering from surgery. And then your age in general. It's always very interesting whenever there is a pandemic flu outbreak, it tends to hit certain ages. If I'm recalling right, the avian flu hit the young and the oldest the hardest. And then the pandemic of 1918 really hit young people. It was really devastating on the world's population because it killed a lot of people who were, you know, the age to get married, have children. It had a major impact. So you need to understand these things and have plans for different types of infectious agents and how your company is going to respond to build your infection control plan. So then engineering and environmental controls. You need to, like I said, recognize that there's different types of disease transmission, and then figure out what effective engineering controls are for that type of transmission. So for COVID-19, you can social distance and wear a mask. And then when you're indoors, you can add ventilation and filtration to the mask and social distancing. And then hygiene, sanitation, and PPE. Again, you need to recognize that different pathogens spread differently. So again, go back to how is it spread? And then how are you going to disinfect and what needs to be disinfected? I always like people to use the least harmful disinfectant possible that still eliminates the pathogen. I really prefer things like that are alcohol based, if that will destroy the pathogen, over bleach based things, just because of the potential for people to become sensitized to the bleach and develop issues like asthma, things like that. But again, you have to make sure whatever you're using kills the pathogen that you want it to. 10% bleach will kill most microorganisms that could be spread in a pandemic. So it is still a very useful, cheap disinfectant. And then figure out what sort of PPE is going to be necessary for your workers for both daily work, a mask, a face shield, gloves, depending on the circumstances. And then for workers cleaning up where an infected person was, maybe that person needs a lot more PPE. Maybe it's something very, very dangerous like Ebola, and you don't even have the ability to train your people to clean it up, and you'd have a professional response, and your response to this blood would be to mark it off, eliminate access to the room, that type of thing. So it's going to depend on what you're dealing with, but you can have a general outline for your infection control plan that you can reference if there is another disease outbreak. The most important thing to keep in mind for your infection control plan is flexibility. It's a framework. You want to review it annually. You want to keep your team trained, and you want to be ready for all sorts of different situations. And then remember the things you learned from COVID-19. You need to constantly be able to adapt to new information and scenarios. How are you going to keep it up to date in a new pandemic or infection situation? And then how are you going to communicate with your employees? Is it through emails, Zoom, in-person meetings? How are you going to keep your people up to date for the particular outbreak you're dealing with? Are there any questions on this?
Yes, we have one question, and it is, can employers require employees to receive a COVID-19 vaccine or show proof that they have already been vaccinated?
So the answer to both is yes, but I'm going to expand on that a little bit more. In general, if you can get your employees to get the vaccine through encouragement and incentives, that's going to go over a lot better than making it mandatory. There's some situations, maybe working in a jail or a healthcare facility where for the safety of the worker, it probably makes sense to have it mandated if you've exhausted the voluntary options. But in general, it's just so much better to encourage people to get the vaccine versus forcing them. And then the second part of the question was, I apologize. Can you tell me?
Oh, you're good. Sorry, I was gonna repeat it. It was, can they make you show proof? like your vaccine?
Oh, yes.
I'm
Okay.
assuming.
So yes, employers can. And actually in Washington State, if you are going to not wear a mask, it's your employer's responsibility to either verify your vaccination or have you sign a affidavit swearing that you have received your vaccination. So that is on the employers at the moment. If you want to not wear a mask in an indoor work environment, you have to have verification. So that's absolutely, I know people get a little confused with HIPAA laws and ADA laws. So HIPAA is just for medical documents, medical professionals. It doesn't apply to most things in the standard world. ADA is to prevent discrimination for people for, illnesses, disability, things like that. Vaccination proof actually has a very long, over 100-year-old standard. So it is completely acceptable for an employer to ask for verification. Good questions. To wrap this up, I want to talk a little bit about what the next pandemic is going to look like. So pandemic influenza is pretty much a given. That's one of the most common emerging infectious diseases that has the potential to be a pandemic. Influenza is always endemic in the background of the population. So like I said, where COVID's probably going to always have some level of infection going on in the background, influenza is similar. Novel pathogens, which means we haven't seen them before. COVID-19 is a novel pathogen, even though it's very similar to SARS. It does, it was unique. Then you can have variations and mutations of known pathogens. Like I said, it's entirely possible there'll be a COVID-19 variant this winter that causes concern. This chart talks about where infectious diseases are most likely to emerge. And you'll notice that the probability is a lot higher in tropical regions, rainforest regions. And those are areas where human development is pushing into these natural reservoirs, and we're coming in contact with novel things through animal droppings, animal bites, animal secretions, things like that. There's potential for so many more reservoirs and so many things that humans haven't interacted with in these sort of climates and situations. And they also tend to be areas where people need the resources, and maybe the management of the resources isn't what is best for preventing the spread of infectious diseases. So it is fairly accepted in the scientific community that there's more risk coming from these places because there's more potential for completely novel pathogens to get passed from animals to people and things like that. So it's an interesting concept. And I do think it's really important to understand, as there's still so much speculation about the origins of COVID-19, but the area where it originated overlaps with the area where SARS originated, and the same bat has that same migratory pattern. So I know there's a lot of different speculation about that, but I think people really should understand that this is most often a natural occurrence, and it's something we really need to be prepared for in the future. And with that, I'm wrapping up our final webinar. Please feel free to reach out to me with any questions or ways I can assist your company with COVID-19 or development of an infection control plan or anything like that. Any other questions before we wrap this up?
There are no questions. That was
All
it.
right. Thank you.